Working with flexor tendon lacerations and repair can be really scary for a lot of therapists. I don't care if you are a therapist with no experience to all the way to with experience, if you're a certified hand therapist. I think there's some degree of difficulty and some degree of fear when it comes to working with flexor tendon injuries. And I think a lot of it just started because there were so many horror stories from like years and years past, but repairs are made so much stronger nowadays. And I think that we're doing our patients a disservice by having that fear still be taught to us and still be ingrained in us. My name is Huang. I'm an occupational therapist and certified hand therapist. And I started Hand Therapy Secrets because I wanted to share my clinical knowledge and help make hand therapy much easier for all of us OTs that when we're first getting started in it. So, whether you're new or you're experienced, I hope that this video can help you. This is just a clip that's coming from the mentorship program that I have. Um, and we go over some anatomy of the flexor tendons. It's just kind of understanding it from its foundation. Because I believe that once you understand the foundational information, that it's going to make being able to stack on the protocols so much easier. Then you're going to really understand, okay, well, what are some of the complications and some of the complexities that come from these type of flexor tendon injuries. And once you understand from an anatomy standpoint, you can then mitigate those types of issues. Scarring is a huge thing, stiffness is a huge thing. We're helping people prevent two things. We're helping them not just avoid the rupture. Ruptures are few and far between nowadays. But I think the other complication is really when we don't move people enough because we are scared and we're not guiding them through. And then understanding like some expectations of like what happens with different people at different times. Anyway, I just want to get started with anatomy because freaking when you get started with anatomy, it's going to make all those other things so much easier. So enjoy this video. Leave me some comments and questions if you have any.
Don't be scared. They are, they are, it's the most boring diagnosis unless there's complications, right? But for the most part, it's really, really boring. Yes, Tanja, extensor tendons are worse. They're worse. They have so many more complications. But because extensor tendons get stuck, no one's ever worried about them rupturing, right? Whereas flexor tendons, people were always concerned about ruptures. And so that's what made it so scary. But I think one, if you know your anatomy, right? If you know your anatomy, you can feel really safe about it. Okay. Two, if you understand the nature of the injury, right? Injury and surgery, you're also going to be really safe to know not just what to do, but also to know what to say to your patients. And then three, the most, one of the other important things to know about flexor tendons is the date of surgery, right? It's really the date of surgery. I always ask date of injury and then date of surgery, right? Date of surgery is key because anything greater to equal to 6 weeks, you're totally safe, right? You really honestly are. You're totally safe to do things. And then at 12 weeks, you don't have any precautions, right? Does that make sense? So the only period is 0 to 6 weeks where you're kind of in this, like, let me go a little slow phase, right? Let me go a little slow phase. And that's it, date of surgery. So I think sometimes we get caught up in the fact that these are, they're lacerated and blah, blah, blah. And like, I think in the past, we were always told as therapists, like, oh my God, you don't want to rupture it, but there's less and less ruptures now just because the surgeries are much stronger. I think that there's been the biggest amount of change. It's the biggest amount of change to any and all, like in terms of protocols and stuff like that, has been done to flexor tendons, right? There's been a lot of research, there's a lot of new stuff. Like if you see a lot of wide awake stuff, even though you might not always see it in practice, the latest and the greatest is about wide awake approach surgery and then getting started early. So for example, if you treat patients that have workers' comp injuries, right, they tend to start really late. If you like I tend to see people a little bit late too, because they'll go in network or whatever, and then by the time they get stuck, they'll come here. So I tend to see them late as well. Sometimes patients are just scared to get started because they think all their incisions need to heal first, when in actuality, their incisions don't need to heal. They need to get moving fast. Right? So one of the first things I want to help you understand is this, so that there's less fear associated with it. And when it comes to flexor tendons, it's really so much about the confidence that you exude when you are working with someone, right? If you feel scared, you'll look scared, and then you won't say things very confidently. But we're just going to break down the anatomy into its most simple form, right? Into its most simple form. And then we'll talk about the different, the nature of the injury itself and the surgery, just to make it so it's less complex. So when it comes to the anatomy of the hand, from a flexor tendon standpoint, you only have 3 tendons, right? You have your flexor digitorum profundus, your flexor digitorum superficialis, and your flexor pollicis longus. Those are really the only 3. So the superficialis starts at the base of P1, right? And the most important thing to note, and I always tell this to my patients as well, your flexor tendon starts at your elbow, passes through your wrist, right? Enters into your hand and inserts right here to bend that middle knuckle, right? So every joint that it crosses, it affects and pulls, right? So the job of the superficialis is to flex the PIP. Every joint that it passes, it secondarily flexes, helps to flex the MP, and also flexes the wrist, right? That's really important to understand from an anatomy standpoint, because if you cut there and you move the wrist into extension and the fingers, MP, PIP, into extension, you're going to put that whole tendon and muscle into its maximum stretch. So right after the repair, you don't want to do that, right? So there's different ways in which to protect it, and it's safe to move. So in your mind, you have to be like, it's safe for me to move. It's safe for me to do certain movements. And if it's safe for me to do certain movements, it's safe for me to do these movements with my patients, it's safe for me to teach them, right? And then you have your profundus. So your profundus inserts here at the base of P3, and it also passes along the way, right? Its main job is to flex the DIP. Its main job is here, and it flexes the DIP. So every joint that it crosses, it flexes the DIP. It helps to flex the PIP, the MP, and the wrist. And so your profundus is really strong, and it's what helps to flex the PIP. So imagine if you don't have a profundus, then who's helping the PIP? Nobody, right? So this is why you'll see in like people with amputations, right? DIP amputations, they they have a weakened PIP. It's because the profundus helps to flex the PIP secondarily. If you ever have someone who's cut just zone 1, right? They cut zone 1 of they cut just the profundus and it doesn't move, or they decide they don't want to fix it. And then like, I can't get enough flexion here. It's because nothing is helping the PIP go into flexion, right? What helps the MP go into flexion are these two flexors, but also remember the intrinsics help the MPs go into flexion. Intrinsics help MPs go into flexion and IP extension. So if the intrinsics help it, it still has a strong base for movement, right? And then it's a muscle, and then it's divided into 4 tendons. It goes to each of the finger. Now, from a nerve perspective, right? From a nerve perspective, the superficialis is innervated by the median nerve, right? The profundus, half of it belongs to the median nerve, and half of it belongs to the ulnar nerve. So you have, your index finger and your long finger or middle finger. And then on the ulnar side, you have your ring finger and your small finger. And the reason why that's important to know is because if you have any kind of nerve injury that is also, related to a flexor tendon type of laceration, or what do I always say about the flexors? Every hand issue is a flexor tendon issue. So if you're looking at a nerve injury and you do not see the profundus moving, then hey, one of the nerves is not working. Is it the nerves not working or the tendon not working? So there's one belly, and then it's divided into tendons, right? Now the flexor pollicis longus, its job is to flex the thumb IP, right? And it's its own little like lonely little muscle, right? It's the only tendon that enters into that tendon sheath, right, for the thumb. And it is innervated specifically by the AIN of the median nerve, right? It's a specific branch off of the median nerve. And so it's gonna just look a little bit differently, but it's just it helps you to understand the anatomy. All right. And that's pretty much it in terms of a muscle tendon issue, right? And so now when it comes to tendons, how do I remember my zones? I remember my zones because I just remember 2, right? So if 2 is here, then 1 is at the DIP, and then 3 is in the palm, right? Pretty much where the distal palmar creases, that's 3. 4 is right in that carpal tunnel zone. And then 5 is down here, right? So if we think about all the different zones, you just have to know or understand the structures that are there. And if you know what the structures are there, it will also help you to understand what are some complications, all right? So if we think about 2 is no man's zone, and it's one of the hardest areas to have a flexor tendon. I mean, all flexor tendon injuries have their issues, but zone 2 has issues because that's where the 2 tendons overlap, and where they overlap becomes really sticky, right? So where they overlap, because what happens is you end up cutting both tendons majority of the time, right? Whereas up here, and in one, you're cutting one tendon for the most part. You're cutting one tendon, but usually the complexity here is the stump at this area is just so small. So it becomes like it's so small that now how are they going to reattach that tendon, right? They can reattach the tendon at two, but then because there's two tendons to fix, that you have too much scarring, too much bulkiness, right? And then three is down here. And three, we have digital nerves that run the side of our fingers, right? So if you cut a tendon, but you kind of cut a little bit of the side, you can hit the little digital artery, but you can hit the digital nerve, right? So the digital nerve, as soon as you cut it, they feel anything you cut distal to that will be numb. So your patients will tell you, I have numbness. So they have digital, but down here in the palm, you also have digital nerves that you can cut, right? So alongside the tendon, depending on like how much of that palm you cut. And then a lot of times you have a lot of scarring here as well. So there's just scarring in general all over the place. At 4, what are you at risk for cutting? Well, definitely very meaty right here, but you can cut your tendon. I mean, you can cut your nerve, you can cut your median nerve. And then for sure down here, when you're cutting the tendons, potentially your flexor tendons here, you're at risk for cutting both. Depending on how far you move to the ulnar side, you're at risk for also cutting your ulnar nerve. So it becomes like, you know, is there nerve involvement or is it just tendon? All right.
We are doing a deep dive into flexor tendon injuries, all the anatomy, all the protocols, all the latest research, and latest protocols, regardless of whether you do them or not. I think it's important to know about them and maybe advocate for your patients. Anyway, there's complexities all around. I'm going to share tips and treatments that are going to help you get better results for your patients. This month, we're going to flexor tendons. The following month, we're going to be going into extensor tendons. So I like to do them back to back, flexor tendons and then extensor tendons, because they all both affect each other. So if you're interested in doing a deep dive into how to better treat these cases, just better understanding, know you're on the right track, have a safe place to discuss, right down below is the link for the mentorship program. So let me know. I hope to see you there.